Yeah, like whoever
Okay,
joined.
so today is a very interesting session, and we have our guest faculty, Dr. Manik. Okay, so Dr. Manik Nicholson is currently a consultant in LVPI Mumbai, and she's trained both in LVP as well as Narayan Netralaya, and she has also worked abroad in China, is it?
No,
And what all
I did
countries?
a short ICO fellowship at Masai. It
Okay,
was one of those ICO fellowships where you do 3 months observation.
absolutely. So we'll have next session for that also.
Yeah,
How
yeah.
to apply.
Sure.
Okay, so off to you, and so Dr. Manik, it's your session. Please take it as you want. And
Yeah.
at the end of the session, if anyone has any doubts, please you can ask questions to Dr. Manik, and she will definitely clear all your doubts. And just will request everyone to go on mute till then. And whenever you are asking any doubts, please turn your mic on and turn your video on. So, Dr. Manik, please.
Thank you so much. Anuj and me are friends from our residency days, and so we know each other for quite a long time. And thank you so much for this opportunity to present today. So the topic which I suggested, because I had presented this somewhere earlier at a presentation in my hospital and then somewhere else, was a little bit on premium IOLs, and the title is just looking like a wow because everyone wants that wow effect after premium lenses. And even though it's elusive, there are a few things which we can do in the pre-op and intraoperative period in order to get that post-operative wow. So the few premium IOLs which I'll be trying to cover in today's class are broadly aspheric lenses, extended depth of focus IOLs, and we'll briefly touch a little bit on trifocal lenses. So I think the first most important thing that all of us try to discuss when we talk about these lenses is a very, very thorough pre-operative evaluation. So a few things which one must keep in mind when they are deciding or choosing cases for premium IOL implantation are to look at the ocular surface and to ensure that there's no dryness, either evaporative or aqueous. Aqueous dry eye can be tested in multiple ways. I won't get into that, but make sure that your ocular surface is good and healthy before you decide on implanting these lenses. Any sort of evaporative MGD dry eye must be treated before you decide on any sort of premium IOL implantation. A good look at the cornea to ensure that there's no other dystrophy, degeneration, any sort of factor which could affect your outcomes must be ruled out. Any sort of cause for bag instability and poor dilatation, such as pseudoexfoliation, although not always considered absolute contraindications, there's sometimes relative contraindications because of bag instability, and these must also be kept in mind when you're planning these lenses. And something important to always check is the retina and ensure that there's no optic nerve or retinal pathology, because not only could it result in suboptimal visual outcomes, but also affect your final contrast and would result basically in a very dissatisfied patient. So the other commonly done tests are, and I'll touch on 2 or 3 in the next few slides. So I think one of the essential tests to get to do well right at the beginning is your biometry. And what we usually prefer to do, especially if it's possible in these kind of cataracts, is an optical biometry. So apart from the optical biometry giving you the routine values, your axial length, lens thickness, CCT, your K values, these optical biometers, and this is the IOL master because this is what we have at our hospital. It also gives you the pupil size, which is sometimes important to look at when you're planning these kind of cases, and we'll come to why a little bit later. The angle alpha and kappa, which I'll also come to a little bit later, and of course your K values, because you need to decide sometimes whether you want to additionally do a toric lens or not in these patients, and that decision can very easily be taken from this IOL master. The other thing we tell a lot of people to always look at in the IOL master is the quality of the scans. Now, the quality of the scans is usually given in the IOL master on the lower few pages, but people don't usually scroll down to look at these pages. Once they see the IOL Master first page along with the keratometry and the alpha values, they don't usually go down and look at this. And it would be a good practice to go down and look at all these quality indicators which the IOL Master gives you, such as these LED lights and the OCT scans, as well as these flagged indicators which the IOL Master gives, which tells you exactly what it thinks that the error is and whether or not you need to repeat the scan. The second important test, which a lot of refractive cataract surgeons like to do, is something called the pentacam. Now, I don't know how many of you all have access to the pentacam, but the pentacam has this one report apart from the regular 4-quad reports that it gives, called this holiday report, and this is meant for primarily for cataract surgeons. So apart from giving you these multiple scans, which include the first scan is the axial, sagittal, and tangential scan, absolute relative corneal thickness, and elevation front to back. So I won't go into details of this. This is a separate class itself. But just to tell you that it gives you these equivalent K readings on the top here, which are sometimes quite useful. And this ratio over here, which is called a Gull-Strand ratio, which essentially has to be normal for most of your IOLs to work. So if you had a patient who's undergone prior LASIK, who's not giving you the history of that, you would probably come to know from this ratio. It also, just like the IOL Master, gives you pupil diameter, white to white, as well as this one important aberration called the spherical aberration, which we'll come to in the later slides as to why it's important. The holiday report also gives you this very interesting EKR detailed report. Now, this becomes more important in toric IOLs, but the only thing I'll sort of point out in this class on premium lenses is that it's a good idea to just eyeball this report if you have the option of getting this scan. So it gives you the keratometry in the 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, and then the 4.5 millimeter zone, which is usually considered the average pupil size in most adults with cataracts. And what you have to do is look at this peak. If this peak has a very narrow base, that means that the average K values are distributed very tightly around the mean. And therefore, the range of distribution of keratometry across your cornea is quite narrow. So the likelihood of you getting a true keratometry value in that patient, so that you get a good IOL power calculation or a true IOL power calculation for that patient, is more likely in a patient who has a very narrow range of deviation of this triangular peak. If you had a patient with a very broad base or a very broad peak, it might not be a very good idea to counsel the patient or to give very high expectations of implanting a premium intraocular, because the likelihood of you sort of hitting the IOL power on the head exactly correctly might be difficult. Sorry, I think there was something in the chat which I was just checking. Anuj, there's someone who's posted, I think, a number. I'm not sure why. Okay, and the third thing, I'll just go on just very briefly. The Pentacam also gives you this thing called aberrations. Now, I don't know how many of you all have had a chance to look at aberrations in detail, but it gives you something called a Zernicke analysis. And that is basically an image representation of all the higher and lower order aberrations that may be present on that cornea in the 6 millimeter zone. So essentially what is important for cataract surgeons is to look at the total RMS, because you want to make sure your cornea is not highly aberrated in order to put in a premium lens. You also want to look at the higher order aberrations and something very specifically, again, which is given here, which was given in that earlier scan, which is the spherical aberration. Now, what is the spherical aberration? It becomes very important later on. Spherical aberration is this 4th order aberration over here, right in the center. And we'll be describing it a little more later in detail. But essentially what is important to look at is this 1, 2, and 3. So this is coma, horizontal and vertical coma, and the spherical aberration. And you want to make sure all these values are low, less than almost 0.3 microns, in order to make sure that the cornea is not so aberrated or so distorted that your lens would not work. Now, the third important scan, which we usually do for if you have access to this machine, is the eye trace. The eye trace is a ray tracing aberrometer. Essentially, it gives you, unlike the Pentacam, which gave you only corneal aberrations, this is the total eye aberrometer, or a ray tracing aberrometer, which gives you aberrations of not only of the cornea, but internal and total aberrations of the eye. So this also gives you something which is called an angle alpha. and it gives you in the same scan, again, the spherical aberrations in the 6 millimeter zone. And for this patient, it's here 0.2. So it's less than 0.3, which means that it's okay for this patient. Now, coming to a little bit about the angles, we're all repeatedly asked why these angles are important. So angle alpha essentially is important for IOL implantation, while angle kappa is important for us as LASIK surgeons. So angle alpha is important. Angle alpha is essentially this it's the angle between the optical axis and the visual axis. So optical axis is basically what this angle alpha is trying to represent is it's drawn as a line between the visual axis and the center of a line connecting this white to white, or basically the bag, the center of your capsular bag. So essentially this angle is important because what you're trying to judge with this angle is whether your IOL will sit nicely in the center of your bag, and whether the distance from the center of your IOL and your visual axis will be very large. Because if it is very large, especially in multifocal or trifocal lenses, you might not get a very happy patient. And therefore, most of the time, especially for cataract and refractive surgery, we usually advise that these angles in patients for implantation of premium lenses should be less than 0.5 millimeters. So we'll now spend a little time on what these spherical aberrations are. So all of these scans, be it the pentacam, be it the eye trace, all of them are giving us this one value, which was that Z4, or what we call the spherical aberration. Now, why is it so important to us, and why are we only stressing on this one aberration as compared to all others? That's because basically all optical systems are judged by the amount of spherical aberration that they have. In, say, a perfectly in a perfect optical system, you would not have any aberrations, and all the light rays passing either from the periphery or from the center of the lens would come to a focus at a single point, and therefore you would get a beautiful image. However, that's not usually true in most cases. In most lenses, the peripheral area of the lens is different. The curvature of the peripheral area of the lens is different from the central area. And therefore, the amount of refraction you'd get from a periphery of the lens is different from that you'd get in the center, resulting in different areas where these two rays meet, resulting in this aberration, which is called a spherical aberration of an optical system. Any optical system, be it a lens, be it the eye, be it any of the lenses we use in our clinics, be it the camera, this aberration, if present, is called a spherical aberration. Now, spherical aberrations, depending upon whether the peripheral and central rays focus in front or behind, can be classified as positive or negative spherical aberrations. So positive spherical aberrations are basically systems in which an aberration in which the peripheral rays or the peripheral part of your lens is stronger than the central part. And therefore, the peripheral rays are focusing in front of the central rays, which are focusing a little bit further away, resulting in this positive aberration. Now, positive aberrations are known to produce glare and halos, and I'll talk a little bit about in the next slide. And the converse is true for negative spherical aberrations, where the central part of the lens is much stronger than the periphery, and therefore the central rays are focused much before the peripheral rays, resulting in a negative spherical aberration. So this is exactly what the point spread function of a spherical aberration will look like, because these rays sort of, it elongates and produces this long kind of aberration. So when you look at it en face, or when you look at it head on, this is what this aberration will look like in real life. And on the Zernike analysis, this is what the representation looks like in 2 dimensions. Now, why is this important, and where are we using spherical and aspherical lenses? So spherical lenses are essentially regular lenses. All the lenses we use in our clinic, be it 90D, 20D, 78Ds, even the lenses that we have in our slit lamps are all aspheric. Aspheric means it's trying to reduce the spherical aberration so that the optical visual quality of this optical system is excellent. So all of the lenses we use, even in the operating room, the microscope and all, are all aspheric lenses. That is to reduce the spherical aberration. Now, how does this aberration become important in the context of IOLs? So we have our regular IOLs, which are our spherical IOLs, which have a constant curvature on the surface of the IOL. But because they have this constant curvature on the surface, the amount of power that you get within the eye, because of this variability in the amount that the rays of light are refracted, becomes variable, producing the spherical aberration. On the other hand, aspheric IOLs have a variable surface. have a variable curvature on the surface of the lens, and therefore the position at which the rays of light are focused within the optical system are uniform, resulting in a constant power. So why aren't all our lenses aspheric lenses? It would be just easier to make all the lenses aspheric. So that is because spherical lenses essentially are easier to make, but obviously because of this variable power have worse optics, while aspheric lenses are much harder to make, but obviously have better optics. So then it begets the question, what is this Q value? I don't know if any of you all have heard of this before, but you'll see this value often popping up on the Pentacam and in other scans. This Q value is essentially a value which tells us a little bit about the shape of the cornea. While the spherical aberration is one of the aberrations of the entire optical system, and as a part of those aberrations that we saw on the Zernike map. Though both of these are dependent on the keratometry of your eye, the Q value is essentially a value which is determined by the shape, which is a value telling you a little bit about the shape of the cornea. And there's no direct correlation. There's sometimes a lot of confusion on this fact, but there's no direct correlation between this Q value and spherical aberrations. Like there's no mathematical formula which will tell you if you put in this Q value, you'll know that the spherical aberrations of the eye are this much. So most of us know that the cornea, the human cornea, is an aspheric prolate, where the center is steeper and the periphery is slightly flatter. And if we put this in context of the human cornea and with the amount of positive spherical aberrations, what is interesting to note is that most of us have aspheric, human corneas are aspheric prolate, and the normal amount of aberrations which are present in our corneas are mildly positive. And this has been proved in multiple studies. The value which has been determined is roughly found to be around 0.27. And what has been studied is whether this value stays constant throughout life. And they found that yes, this amount of spherical aberration stays constant throughout life. It is positive, and it is of a value of, say, roughly around 0.27 to 0.3 microns. So all of us have this much amount of corneal spherical aberrations in our eye. And it usually starts off at 0 and it stays a little, it might fluctuate a little, but stays essentially constant. The lens, on the other hand, has negative spherical aberrations. And this has also been proved in multiple studies. The negative spherical aberrations of the lens, on the other hand, decrease as we become slowly older, presbyopic, cataractous. And once we undergo cataract surgery, say at the age of 65, 70, you've undergone cataract surgery. And if you've implanted a lens with positive spherical aberrations, what you've done is essentially increased the whole eye spherical aberrations, because your cornea anyway had a little bit amount of positive spherical aberrations, and you put in a standard lens additionally with a little bit more amount of positive spherical aberrations. So this essentially is from a very nice video by Dr. Mazen Sinjab, which is available, and I would recommend everyone see it because I've learned a lot from this video online. But essentially what it shows is the relationship between spherical aberrations, contrast sensitivity, and depth of focus, because all three of these become very important when we're talking about premium lenses. Spherical aberrations are always present in our corneas. And what we saw, the value was around 0.27 on the positive side. They are very small, and therefore they are not so high that they are toxic to our visual system. They are in the non-toxic range. What Dr. Mazen Sinjab and a lot of other people say is that when your optical system has zero spherical aberrations, the contrast or the quality of your image is maximum. But essentially what it does is it has zero depth of focus, and we'll come to this a little bit when we talk about extended depth of focus lenses. As you increase the spherical aberrations of any optical system, be it the eye or any other system, the contrast sensitivity comes down a little. But what you get with an increased amount of spherical aberrations is a little bit amount of depth of focus. And we'll see how lens manufacturers use this in extended depth of focus lenses. So just summarizing what we spoke about, when you're young with good accommodation, your cornea has a little bit amount of positive spherical aberrations, your lens has a little bit amount of negative, and therefore overall your system does not have too many aberrations, and you have an excellent quality of vision. As you start becoming a little older, as your lens negative spherical aberrations come down and the total eye aberrations start increasing positively, your whole eye system has a little bit amount of positive spherical aberrations, but this helps in a way because by the age of 40, 45, as you've started losing accommodation, that little bit amount of positive spherical aberrations, though it reduces the contrast sensitivity, does increase your depth of focus a little, and therefore does help you a little at this age when you've started losing accommodation. As you grow even older and develop a cataractous lens, your vision starts becoming cloudy, and then all of this doesn't matter at all. And if you replace your cataractus lens with a plastic lens, you have the option of either correcting those aberrations or not correcting those aberrations. So if you implant a conventional lens, that lens will have positive aberrations. You have the option of implanting aspheric lenses, which have either negative or zero spherical aberrations. Now, you get lenses manufactured by various companies, and they'll tell you on the box, or usually it comes with the leaflet which comes inside these lenses, on how much the aberrations in that lens are. And traditional lenses will give you this kind because the total positive aberrations of the eye are increasing, and therefore the quality of vision that you will get will not be great. If you implant a zero spherical aberration lens, you are essentially still leaving behind a little positive aberrations of your cornea, and therefore you will not get a great quality of image. But if you implant an IOL with negative spherical aberrations, what it's essentially doing is negating the positive aberrations of your cornea, and therefore the total optical system is neutralized now, it's zero. And therefore the image quality you get is great. But again, it comes at a cost. This is because when your optical system has zero aberrations, the quality of vision is great, but the depth of focus that you get is very limited. While if you have some amount of spherical aberrations left in the eye, it comes at a bit of a compromise. Your quality of vision might not be as great as that in an optical system which has no aberrations, but you get a little bit more depth of focus. So we just decided to go back and make a list of all the kind of lenses that we commonly use and look at what kind of situations they are best suited for. And this is a common sort of table which was charted out by Dr. Uday Devgan, and you'll find it on his channel as well, where what he recommends is that if a patient has weak zonules or is the cataract surgery is likely to be decentered, don't put any sort of lens with aberrations. It's better to go in for a zero aberrated lens, such as the J&J AR40 Sensar lens. And if you've had a patient who's had previous myopic LASIK, that is a highly positively aberrated system, then it's best to put in a lens with negative aberrations. So we've spoken a lot about all this, but since these aberrations are so small, does this really make any effect in your real life? Or does this really matter to patients? Or do we need to go into so much of an explanation to think about what lens we need to implant in these patients? So what one large meta-analysis found was that the best corrected visual acuity amongst various aspheric IOLs was almost the same. What it did find was that aspheric IOLs had better quality of vision under mesopic light conditions. And this becomes very important. And I'll have a video later on which will explain why, which is because the pupil size increases in mesopic light conditions, allowing more light to enter the eye. And these aspheric lenses, which reduce the spherical aberrations, which is a pupil-dependent aberration, becomes more important when the pupil is large. And therefore, if you find, how does this clinically make any effect to us? If you have a patient who drives a lot at night, who works a lot under dim light conditions where the pupil is likely to be larger, it might be in some way better to implant an aspheric lens in him. So this is what the image would look like, a regular image, good BCVA, good contrast. But if you were to implant an aspheric lens, this is what his vision in real life would look at. Standard lenses have an almost 20% reduction in contrast sensitivity as compared to aspheric lenses. And this was proved by a study which was done where what they did was they took a regular spherical lens and an aspheric lens. So SA6080 is your regular Alcon spherical lens, and the aspheric version is the IQ, which is the SN60WF. They used these US Air Force testing cards, and they took these lenses, put them inside a camera and took images of these test cards. What they found that was that the quality of vision in this aspheric lens, which was implanted here, was much better than that in the spherical lens. However, it's essential to ensure in these lenses, which have some amount of spherical aberrations, to ensure that there's no tilt. You can see over here, they induced a slight amount of tilt of minus and plus 3 degrees. And then the quality of image suffered a little. So this is that last video which I was talking about, that this spherical aberration is dependent on pupil size. So if the pupil size is large, more amount of light is able to enter the eye, hit this lens and come back onto the retina. But as the pupil size increases, these peripheral rays are cut off, and therefore the spherical aberration also essentially reduces. Therefore, these aspheric lenses might be more beneficial, as I was saying earlier, in patients who have large pupils or maybe work more in dim light or drive a lot at night. So one last thing that we were thinking about was whether you need to customize the asphericity for every patient, because you're getting this spherical aberration value of the cornea on the pentacam as well as the eye trace, and whether it makes sense to match that spherical aberration value with an aspheric lens. So a lot of studies were done, and it was found that it really didn't matter. And I don't think I've seen any senior surgeons do this either. So I'm not sure if anyone does this anymore. So a few take-home points on aspheric lenses. Just to summarize what we spoke about just now, that the corneal spherical aberration stays constant, as we saw, at plus 0.27. But the human lenses changes with time. Aspheric lenses will produce a superior quality of vision and contrast, with, however, at the expense of depth of focus. It is important to consider the amount of spherical aberration, especially not maybe routinely, but more importantly in patients who had previous refractive surgery. And the spherical aberration increases as the IOL power increases. So this was a little bit about aspheric lenses. Dr. Anuj? Okay, so maybe I'll just go on to the next part of what I was going to talk about, which is a little bit about extended depth of focus lenses. I'll just check the chat to see if there's anything. Okay. So if there are any questions, please leave them in the chat. I'll be happy to answer any of them and get back to you all as soon as I check the chat in between. So the next thing I thought we talk about a little bit is these other lenses. So this is actually images from our clinic where we work. To the left, we have a young fellow, Dr. Hardik, who's a pediatric ophthalmology fellow. And to the right, we have his senior, Dr. Jenil, who is part of our pediatric ophthalmology department. Now, Hardik is quite young, and you'll see that even at this distance, he can accommodate quite well. He can bring images onto focus on his retina and see all objects quite clearly. You'll notice that Dr. Jenil, even though this is a poor representation, he's not actually that old. As we grow older, as our accommodation reduces, we become more dependent on this one entity, which is called depth of focus. Depth of focus is the ability for humans or for for us as with our optical systems to bring into focus an image on our retina in the absence of accommodation. So in the absence of accommodation, how easy is it for you to bring an object into focus and see it clearly on through a small range? So this is one video which I found online, which actually summarized this beautifully. So I'll just pause it here. This is an image E, which is at infinity. This is our retina, which is seeing this image E, which is at infinity. And this is our brain, which is interpreting this image E. Now, in an optical system which has zero spherical aberration, this E is very clearly focused because all those rays of light are focused here and there's no aberration in this system. And therefore, we are seeing this image very clearly and very sharply. However, because there is no aberration in this system, as soon as we move this E a little bit to the front and back, this image becomes distorted, and so is our interpretation of that image in our brain distorted as well. This is because even though, as I said earlier, the quality of the image is great, because there's no spherical aberration, there is no depth of focus. And therefore, in a system which has no accommodation, a little bit of movement back and forth results in an absolute loss of vision, because we don't have any depth of focus. Now, say we increase the aberration of the system to some extent, to a little extent, say until that non-toxic zone, which is what Dr. Mazen Sinjab keeps talking about, the quality of image on our retina suffers a little. But because it's in the non-toxic zone, our brain is still able to interpret this image quite clearly. So now with this little bit of depth of focus, if this image is moved to the front and to the back, we can still see this image quite clearly, and our brain interprets it as a clear image. But we are also being able to take advantage of that little bit of depth of focus by still being able to view this image clearly. Now, however, if we move the image beyond, say, that level of spherical aberration, then the image starts becoming a little blurred and our interpretation starts becoming a little blurred as well. Now, say we increase the spherical aberration of the system beyond that threshold where it's now become toxic, then the entire system has too much spherical aberration, and therefore now what our brain interprets as well is a blurred image. So essentially, again, what we're trying to do with spherical aberrations is to increase the depth of focus at the expense of loss of a little quality of vision. So EDOF, this is essentially the concept what most manufacturers use in extended depth of focus lenses. Now, I don't know how many of you all have had experience with using these lenses, but there are a wide variety in the market, and most manufacturers try to use this concept of extending the depth of focus by playing a little around a little bit with spherical aberrations in order to sort of cheat the eye into thinking that it has a little bit of accommodation. So essentially, monofocal lenses will focus all lenses at a single point. Multifocal lenses will have 2 or 3 focal points, depending on whether they are multifocal or trifocal lenses. Essentially, what extended depth of focus lenses do is extend the depth of focus using a little bit amount of spherical aberration. So in a plano system, all the images are focused right onto the retina. If you are a little bit of myopia, these images are focused here. So you'll be able to see a little bit of near, but the image will be blurred on your retina. And so you won't see distant images clearly, though you will be able to see a little bit of near. We don't want that as well, because that's not an ideal system to have. You can have a system in which there is a little bit amount of astigmatism, but essentially what this is doing is producing a Sturm conoid. So you will have 0 over here and minus 1.5 here. But both of these images are blurred. So this is also not the ideal situation what we want. An ideal situation will be where we have a beautiful, clear image through this entire extended depth of focus. So we'll see how each of these lenses, the Vivity, the Symphony, and now the Supra 4, which is now manufactured by Appasamy, which is essentially quite similar to the Vivity, are sort of bringing this into their optical system. So the first lens is the Vivity lens. The Vivity lens essentially, and I've taken this out of their website of itself. What they say is that it has a small plateau of 1 micron, which stretches the wavefront, producing a continuous focus area. And it also has a discrete change in radial curvature in the central area of 2 millimeters, producing a wavefront shift. So what essentially this lens is doing is what we saw earlier. What it's doing is extending this depth of focus using this small 1 micron central plateau in order to bring the image focused onto the retina, but to also give us some amount of intermediate vision. But what we need to remember, and what most people sometimes overlook, is that these lenses are reducing our contrast sensitivity by reducing this extended depth of focus. So a lot of us think that these extended depth of focus lenses are great and they produce excellent vision and there's no side effects at all, and they don't have any glare halos, no loss of contrast at all. But this is essentially a screenshot that I've taken out of the warning label that comes with that leaflet which comes inside the lens box. And what they clearly state, and what Alcon clearly states, is that most patients implanted with the Vivity IOL are likely to experience significant loss of contrast sensitivity as compared to a monofocal lens. So as compared to, say, your aspheric IQ lens or any sort of single piece lens. So this is very beautifully illustrated in this modulation transfer function defocus curve, where what essentially these sort of curves do is show you by how much the contrast is reducing. So the gray dotted line is essentially the Alcon single piece IQ lens, and the black dotted line is the Vivity lens. And just by looking at it, you can understand that the difference between the two at the 0 defocus position is the amount of loss of contrast. Modulation transfer function is essentially a function of quality of vision. And essentially, this is the amount of quality of vision that you're losing by implanting a Vivity. So the contrast loss is essentially this much by implanting a Vivity lens. Even though it might not be as significant as, say, other lenses, this is still something to discuss when you are implanting this lens in a patient. It's still something to keep in mind, especially when you're implanting these lenses in patients who already have significant loss of contrast, like, say, glaucoma patients or patients who have other ocular surface conditions. So the other extended depth of focus lens is the Symphony J&J, Symphony lens manufactured by Johnson and Johnson. This essentially has a posterior, this essentially is an EDOF lens, which has a very different technology which is built into it. It has these rings, which it describes as a posterior achromatic diffractive pattern with an echolette design. So it's basically an echolette design on the posterior surface of the lens. This is also aspheric, available in a range of 5 to 34. But now, in addition to causing a loss of contrast, it must be remembered that because this lens has rings, it also produces glare and halos. And this again is the warning package which comes along with the lens, where they clearly mention that you may experience some halos, that is rings around light, glare, that is reflected light, making it difficult to see, and starbursts, which are rays around the light. And this was not present with the Vivity lens because that just had that central elevated bump. But this may be present with the Symphony lens because it has this echolette design. The defocus curve of the Symphony lens is in blue over here. And the defocus curve of the J&J counterpart equivalent monofocal lens, which is the Technis ZC Blue, is in red over here. And essentially at the zero defocus, you'll find while both of these lenses have give you great visual acuity almost over here, 20/20 at the zero defocus curve. As you start going towards the 1.5 diopter, you'll find that the monofocal lens starts falling off in terms of quality of, in terms of the amount of vision that you have. But you'll notice that with the Symphony lens, it maintains this good vision right through the 0.5 to 1.5 defocus curve, and then slowly starts dropping off, but still maintains that 1 diopter advantage over the monofocal lens at all of these defocus points. So another lens which has become quite popular, and I thought I'd just put one slide about it, is the monofocal plus lens, which is the Eyehance lens manufactured by J&J. Basically, what the company guys say is that it has a smooth and continuous transition of power from the periphery to the center. So there's no rings, no central elevation, no demarcation lines. It just has a tiny central plateau, producing a local change in refractive power. It's also aspheric, available in a range of 5 to 34 diopters. And this lens, unlike any of the other lenses we spoke about previously, has no photic phenomena, no glare halos, and no loss of contrast sensitivity. So this slide is courtesy Dr. Uday Devgan, and I don't know if any of you all watch his videos, but this is an excellent slide from one of his videos, which I go back to quite often actually. What he did is he superimposed all of these defocus curves onto one common image. And you'll find that he took Alcon and Technis. So basically, he's taken the Alcon IQ lens, which is in yellow. He's taken the Technis lens, which is their monofocal aspheric lens, which is ZC Blue. So both of these lenses are here, and you'll find that at zero defocus, these give you the maximum or the best image quality because these are your monofocal aspheric lenses. The pink line is the Vivity, the pink line is the Eyehance lens. And you'll notice that there's a slight decrease in the amount, in the quality of vision at the zero defocus, but still not as much as this green line, which is the Vivity IOL, which has a much sharper loss of contrast at zero defocus as compared to all the others.
Dr. Manik, your audio is shut.
My audio is on.
Yeah. Okay. So
Oh, yeah.
you were not speaking.
Sorry.
Okay. Yeah. Okay.
Did you operate and come so fast?
No, that is just to show that I operate.
Okay, fine. So I don't know, was I audible for the last couple of minutes?
Yeah. It was just yeah. Yeah.
Okay, fine. So I was just talking about these defocus curves, which sometimes, which what Dr. Uday Devgan mentions is that what he did is he recommends that because the Vivity lens has a much better quality of vision and a much better range of vision over the 1 and 1.5 diopter range, or essentially the 1 millimeter intermediate range, it recommends that for the second lens, you keep only a 0.5 diopter difference between the two eyes in order to get even better intermediate and near vision. However, if you do this 0.5 diopter for the Eyehance, you might not exactly hit the N6 mark. And therefore, what he recommends is a larger amount of monovision for the Eyehance lens, because this is essentially a type of monofocal lens itself. So again, coming back to this question, can we implant these lenses, these premium lenses, what we just spoke about, these EDOF lenses and all these out of the box situations? So a lot of times we wonder whether we should implant it in glaucoma and high myopes, in these patients who've had previous refractive surgery. And it's very much dependent on the surgeon, on your comfort, on the patient understanding the side effects, what we just spoke about, loss of contrast, rings, glare, halo, all of that. If they're clearly explained to the patient, if there's not the extent of amount of damage, the extent of kind of vision, what their aspirations are from that kind of lens, the amount of money they're willing to spend on the lens, if we have an in-depth discussion about all of these situations with them, I think there's no absolute or relative contraindication to using these lenses. Basically, it's a one-on-one decision that we take with the patient. Something to essentially remember in patients who previous refractive surgery, I would put this in a whole separate group as compared to these patients, because these patients are much more demanding than that earlier set of patients. They've always had better vision and they always want to be their demands for spectacle independence, or their want for spectacle independence, is much higher than that previous subset of patients. And I would say IOL power calculation in these kind of patients, in order hitting the nail on the head, as I said earlier, is a little bit more difficult in these post-LASIK, post-RK patients. And I would say especially over-promising and under-promising and over-delivering in this subset of patients is very important to remember. So last few slides, basically, it's essential to sweat the details. You can either use a guidance system like the Callisto or something if you have access to it. If you don't have, then using a marking the center of the cornea, ensuring that your lens is well centered, using a capsular rhexis marker. These are all things which you can use to improve your quality of cataract surgery. If you can try to sit on the steep axis, even if there's a little bit amount of cylinder, it'll help correct that little bit amount of astigmatism. But obviously, if it's larger than what is correct, what you're able to correct with your 2.2 or 2.8 millimeter incision, then it's best to consider a toric lens as well. If there's a good, make sure that your IOL has a good overlap and is well centered, and centration with your Purkinje images at the end of the case, in order to ensure that that angle alpha, which we earlier spoke about, the one between the center of the lens bag and your visual axis, is to a minimum, so that the optical quality of that lens can function best in that eye. And sorry, yeah, this should have come earlier. Sorry, this is the last one slide on trifocal lenses. Trifocal lenses essentially are based on this diffractive lens technology. They have the commonly used one, which most of you all must have heard about, is the Panoptix lens manufactured by Alcon, which has a near ad of around 3.25, an intermediate ad of 2.17, and aspheric in technology. There have been multiple studies which have proved the efficiency of this lens over multifocal lenses in combination with EDOF lenses. And I won't go into details. Suffice to say that these lenses have now been extensively tested, and you will find that the quality of vision with these lenses supersedes Restore and all the other multifocal lenses, especially at your intermediate and near distance. So setting the stage, this is something that I spoke about earlier. What is the motivation, the needs and lifestyles and personality of your patients, and always overpromise and under-deliver. And anticipate post-operative problems. Sometimes just an early PCO might be the cause of dissatisfaction of the patient, and it's not really something to worry about. An early YAG sometimes benefits these patients as well, and dysphotopsias is something you need to watch out for. But again, I won't go into too much detail about this here. So options for unhappy patients include IOL rotations if they're toric lenses. You always have the option to top up if it's a PRK or LASIK. You can always consider an exchange, though we keep this for the last. Sulcus fixated IOLs, though I don't have much experience with this. And last, of course, if nothing else works, you convince the patient that it's his problem and that he needs to neuroadapt with that lens he's paid so much money for. So thank you so much. Y'all can email me at any time with any of your doubts, or even if you just feel like reaching out with any of your cataract conundrums, I would be happy to answer them if I know the answers.
So,
So I think there's one question in the chat.
yeah,
Sorry.
we are done with the slides, doctor.
Yeah. So there's one question which is on the difference between trifocal and multifocal lenses. So honestly, I don't have much experience with multifocal lenses, and I've done a few trifocal lenses. Mm. Trifocal lenses are basically lenses which have have good quality of vision at distance, intermediate, and near, while multifocal lenses are essentially bifocal, that is for far and distance. Though now what I understand is most companies are phasing out their multifocal lenses, and now because trifocal lenses have sort of taken over the market, most of us have now slowly switched over to trifocal lenses because the obvious advantages of these lenses over multifocal lenses and that they produce good intermediate vision as well. They're producing greater quality of distance vision as well. With the panoptics particularly, I've heard that the quality of vision is great as well, and the incidence of glare and halos at night has lowered down as well. So, but yeah, I don't have much experience with multifocal lenses per se. We've put in a few toric trifocals and regular trifocals.
Lovely. So, anyone has any other doubts? Dr. Manik is available for some time. So, if
Oh, you all
anyone
can just
wants to
email
ask,
me your doubts. So I'll be happy to answer any of your doubts. I'm on LinkedIn,
she's
Instagram,
there,
Facebook.
she's there right now.
So
So,
yeah, you can contact me.
so
I'll leave my email ID in the chat box.
yeah,
So
we'll say, but what I wanted to know
yeah.
uh, is are these premium lenses becoming standard of care? Is monofocal now, what do you say, an exception, or what is?
Oh, no. I would still say monofocal is the rule rather than the exception. I would say your premium lenses, especially in the cohort of patients that we see. I mean, I would not compare myself to all of these patients who are and these surgeons who are abroad because they have these high volume premium lens practices. And I think partly that is because most of their patients are covered by insurance, while in our country, most of our patients pay out of pocket and their insurance doesn't cover most of these premium lenses. So a lot of patients usually try to stop at your best monofocal lens, and only if you really want, if they're really motivated, they might go ahead from either for a trifocal lens. But I would say still majority of the practice is good monofocal lens. And I sometimes feel that while we're pushing so much for monofocal lenses, even if you do a good monovision in some of these patients who are not particularly overbearing or over particular, then you might still give them excellent quality of vision, apart from everything that I said in terms of aspheric and all of that. Even those kind of lenses do very well for most of our patients. And we've seen that a little bit amount of monovision gives them good intermediate vision or functional intermediate vision, I would say.
So apart from the cost, if the cost is not a limitation, would you inject EDOF or a trifocal in all your patients?
Yeah, definitely. Again, it depends on what the patient's expectations are, what his needs, visual needs are. So a lot of talk goes into it, whether he's had previous history of surgery or not, how much he is willing to use glasses after surgery for reading, whether he's willing to have a little bit of monovision as well, whether he's understood that concept as well. And if nothing else, and if he has the budget for it, then of course, trifocal lenses are great lenses. And I've had some senior surgeons telling me that they've implanted them quite routinely, and they've found that the incidence of glare, halos, and all of these other complications that we usually worry about are quite minimal as compared to the earlier generation multifocal lenses.
Okay, so the future is the premium lenses.
I guess so.
Okay, okay.
If they bring down the cost, or if Appasamy decides to make panoptics equivalent.
Absolutely. I think the cost will definitely, with the volume going up and with manufacturers coming up. Yes, Shaiban, can you use the mic for your question? I think Shaiban is.
Good evening, ma'am.
Hi, hi.
Yeah, ma'am. So I wanted to know that if someone is practicing toric intraocular lenses, the premium ones, So, is it always required to get a Varion done before going for a toric lens, or can one go ahead with toric lenses without a Varion also? Just with the normal axis marker.
Oh, got it. Okay. So I was gonna actually tell Anuj that I have a whole actual presentation on toric lenses. I can answer your question there. But essentially just answering your question, absolutely not. You don't need a Varion at all. There are really good toric markers which are available in the market, including your bubble marker for the slit lamp and intra-op. You have so many ways of marking the lenses before you put them including just the regular markers which we use with the pen to mark the location of the lens. So I don't think you need Callisto Varion at all. I mean, depending on what you have for doing toric lenses. People have been doing them for years without any of these marking systems.
Okay, ma'am. Thank you.
And one more question which everyone they generally ask is, do you need a separate sort of training to learn the art of these premium lenses?
Oh, no, I don't think so at all. I think if you can do a good phaco, get a nice well-centered IOL in the bag, do a good round, nice capsule or excess with a good overlap, and do a clean surgery. I don't think you need I don't think there's any additional, I don't think we do anything different in these lenses at all. You're just implanting a premium lens as compared to a regular lens. So there's nothing different that we're doing in these lenses surgically as compared to any other lens, in my opinion. Just to do a good capsular polish, ensure that your axis is nice and well centered. That's about it. And I try to sit on the steep axis. That's something additional I do. So if I know he's steep temporally, I'll sit temporally. I know if he's steep superiorly, I'll sit superiorly. The only additional thing which maybe you can do to get that wow is maybe become a little more confident in doing topical phacos, because you want the patient to look at the light, you want to center the lens nicely on your Purkinje images, you want them to start getting up and you put those glasses on. It's just basically about the experience that they have through the surgery. But even that, I say, would not be essential to starting premium lenses at all. Even if you give a nice block to a safe surgery, I'm sure patients will be absolutely happy the next day. So there's one question, I think, which Radhika has asked. Hi, Radhika, if you're there, hi. Do you do an eye trace? No, not at all. We don't have an eye trace at all. These were just images that I took from my time at LVP. And we don't have an eye trace at all. It might not even help much. The only additional thing that the eye trace is doing is giving you directly this angle alpha and kappa and giving you separately this spherical aberration. But you really don't. We all implant IQ lenses and we don't look at the spherical aberrations at all of the system. But this is just one additional thing that the eye trace is giving you. And if you anyway have it, you can include it in your checklist of things to do before implanting these premium lenses.
Hi, thanks, Manik.
Hi,
I
hi.
just had another point because I saw a couple of videos of Alcon also,
Yeah, yeah.
and they were mentioning that, most of them take into account angle alpha before, going for these.
Yeah.
So that's why I was wondering, is
So I
it
think
really
that's a bit of
necessary?
a myth around this angle alpha. Angle alpha
Okay,
is basically I'll just tell you what I've understood of angle alpha. Basically, if you draw a line through the capsular bag, horizontal line, and you take the center of that line, so the center of your bag, where the lens is going to lie, and you subtend that angle with your visual axis. That is angle alpha. So it's essentially the difference between the angle that your IOL is making, the center of your bag with the center of with your visual system. So how far away is your lens going to be from your visual axis? So that is your angle alpha. So essentially what these things are trying to tell you is that if it's very far away, if the angle alpha is very large, then you might have a decentered, premium lens, trifocal or something like that. The patient might not be very happy. But if you actually go to see that 0.5 millimeters is so small, 0.5 millimeters, most of us don't even realize when we're doing cataract surgery. And sometimes I feel that maybe this angle alpha is a bit overhyped. Like not doing a panoptics because your angle alpha is 0.6 or 0.7. I'm not sure how
right.
relevant that is. So this
Yeah.
might still be something which you can debate about. But
Right.
I would maybe not simply say that I would not call it an absolute contraindication.
Okay. Thank you so much.
Not at all. I think this is something which, like, it's just like spherical aberration. You can look at all these tiny things and maybe decide, but I would not, I would not put too much importance on it.
Thank you. Thank you.
So, ma'am, will there be any difference between Appasamy lenses or Orolab lenses and imported high-cost lenses if both are read-off or trifocal? So, I honestly don't have much experience with the in-focus. I don't know if anyone in this group has. I've maybe used it only once or twice, and I think they were okay. And essentially, I used it because the patient was not able to afford one of the higher, the cost of one of the higher lenses, but they still were young and they wanted an EDOF lens. So we decided, okay, we'd go ahead and put the in focus in, and we did a little bit of monovision with it. But other than that, I've not had much experience with Indian premium lenses. So I'm sorry, that's the only lens I've probably used. And Ekta, hi, how are you? Okay. Can we have videos on toric marking pre-op? That would be okay. Yeah, sure. I have a whole presentation on toric lenses. If you want, I can.
We'll have it next
Hi,
week.
Manik.
Hi, how are you?
I'm good. How are you?
You all guys
Excellent
are
presentation
attracting
as
more premium
always.
lenses than me. I should not be taking this class if you you should be taking this class.
No, you were really great.
Okay, if there's anything, let me know. But I have a lot of videos. Maybe if Anuj allows me, I will show it next time. Yeah.
Dr. Manik is busy, that's why she is not available for the class. So
No. So
for
if it's
trifocal,
okay,
definitely we will for toric next session
sure.
whenever we get time. And one more question which residents do ask us about the investment. So can we go for ultrasound biometry for premium lenses, or do we need
You
optic?
can. I know people who are doing it even with ultrasound biometry. If you're sure that the results of your ultrasound biometer are good, I mean, there's no harm in doing it at all. And if you know that you're getting good readings, it's fine. Only thing is, make sure your keratometry is accurate. That's one. And in Bombay, we have the advantage I've seen of just calling these optical biometers. It's so easy to just spend that little money and get an optical biometry done, especially if the cataract's not very hard. So I would say still, if you do have the ultrasound, nothing else, then yeah, obviously it's okay. But if you have the option of even just calling it and getting it done, I would say still try to get that done. It's just ways to increase your accuracy of doing these lenses. There's no hard and fast rule that you can't do it with an ultrasound biometer. But if you have the option of maybe doing something which has been proved to be a little more accurate, it's always good to cross check, because that one time you put that one lens in that patient's eye, you're not going to go back and have a second chance of replacing it. So I would try to maybe cross check if I had the option.
So what is the minimum threshold? It's like an optical biometry, or do you have to have a
I
pentac
would say an optical biometry, that's all. That's the minimum threshold.
and rest, the microscope and rest would be your
Oh, no,
usual?
all of these are frills and whistles. All of that is, if you have it, it's great. If you don't have it, you're not losing anything.
Okay.
You just have extra things which are increasing your accuracy of these lenses, but you're not really, I mean, I don't know. We've worked in places where they don't have anything and just the optical biometer, and we've got good results as well. So I don't think it matters that much. A lot of this, I feel, sometimes is company driven as well, because all of these companies are manufacturing microscopes and phaco machines. So everyone tries to one up the other sometimes with the cameras.
Yeah, and in the conferences, you generally hear people talking
Yeah, no,
with
I think
machines. So even if they don't mean it, but that is what the message goes that
yeah. No, I think if you're a good phaco surgeon with any machine and you can put an end lens nicely in the bag, I don't think there's anything wrong in doing these premium lenses.
anyone else having any doubt? Because Dr. Manik is ready to run away anytime. So
Yeah. I put my email in the chat, so please let me know. I'll be happy to answer it. I can put my phone number in, or you all can take it from Anuj and he'll give it to you all. But if there's anyone who needs any help with just regular phaco stuff also, please feel free to reach out. Huh?
so we'll call it a day. I think that's it's been really this. And the messages are already pouring in that how much the session has really helped. And I think these points which you have made, now I feel that I'm totally alien to all these things because I don't understand much of it. So it is good that as you said that if you can do a phaco, then maybe I'll also try putting these lenses someday.
Definitely.
Maybe
That is the purpose of this class. The day you put in your premium lens, put it on clinical peanuts and tell everyone that that's what you did.
So really, really nice to have you and thanks for sparing time. And let's hope to catch up for another session, maybe for Toric, if time permits, whenever you are free. Because when we did the poll, I think the premium and Toric both were there together, and they really got the maximum number of votes. And
Yeah, sure. I
so
have one on Toric. I'll
sure.
pull it out. And then if anyone has anything on Phaco they'd like, they can let me know that as well. But I'm not
Absolutely,
sure.
absolutely. So maybe next session we can have on Phaco and then we can go again on Toric. So that because the residents who are in the starting phase, that will be a good session for them. And thanks again, and
Thank you
hope to
so much.
catch you soon.
Yeah, see
Thank you
you.
everyone for joining, and
Bye. Bye.
we'll try to upload this session as soon as possible. Okay, bye.